Hello everyone, and welcome to today's webinar, Tumor-Targeted Fluorescent Dyes for Fluorescent Guided Surgery. Before we get started, I would like to go over a few items so you know how to participate in today's event. You may have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. It is my pleasure to introduce Dr. Philip Lau. Dr. Philip S. Lau is the Presidential Scholar for Drug Discovery and the Ralph C. Corley Distinguished Professor of Chemistry at Purdue University. Dr. Lau has devoted more than 45 years to exploring novel drugs for treatment of human diseases, characterizing the structure of the human red blood cell membrane and defining signal transduction pathways in plants. He has published more than 450 scientific articles and has more than 75 US patents or patents pending. Dr. Lau has also founded 5 companies to translate his discoveries into the clinic. And without any further ado, I hand it over to you.
Good morning, everyone. Thank you very much for joining us so early in the morning. I plan to talk this morning on some of the new tumor-targeted fluorescent dyes that we're developing for fluorescence-guided surgery. And I guess since we're short on time, without further ado, let's switch over and begin the seminar. So let me begin by just describing the general structure of tumor-targeted fluorescent dyes that we and others are developing. These dyes all contain a targeting ligand. The targeting ligand I'll define in the next slide. And then these targeting ligands are linked via a spacer to either a very bright fluorescent dye that is visible to the surgeon during the surgery, or to, in some cases, the same strategy is used to deliver therapeutic agents. In the case of optical sciences, we often use photodynamic therapy drugs for this application. So let's jump to the next slide and look at the nature of these targeting ligands. And they can be used, as you see in this slide, for delivery of the attached fluorescent dye to all sorts of different diseased lesions, including cancer, inflammation, infectious diseases, fibrotic diseases, and so forth. So throughout the fluorescence-guided surgery world, there are a lot of different sizes of molecules that are used to carry attached fluorescent dyes to diseased tissues. And I'm going to focus today primarily on targeting fluorescent dyes to tumors. Many people use antibodies. These are large, 150,000 Daltons or 150 kilodaltons molecular weights. I won't spend much time on any of these. I'll spend most of my time on the very last one. But just to go through some of these, then there are a lot of pieces of antibodies that are shown here along the top row. And after that, then there are others that have used other parts of proteins that they can mutate infinitely to find sequences that will recognize a tumor-specific antigen. And these go by a number of different names. They're DARPins, adnectins, affibodies, nautins, centurins, bicyclic peptides. And finally, at the far end, you'll see what we mainly focus on, excuse me, and these are low molecular weight organic molecules that have to be designed to fit into binding sites on tumor-specific antigens. And to these, we can also attach a fluorescent dye. Those are the smallest ones. And the next slide shows why we are interested in using the very smallest molecules. And this is a video where we're looking through a window into a tumor on the surface of a mouse. And we're looking at the targeting of a targeted rhodamine molecule, a targeted red fluorescent dye, over a period of time, we're looking at its accumulation. And if you then look at this same blood vessel at a number of different times following injection into the tail vein at a distant site of the targeted fluorescent dye, in this case, we're looking at the delivery of a folate linked to rhodamine via a PEG 5000 molecule. And this conjugate has a molecular weight, obviously, of about 6,000. It's not large, but it's not really small either. And over the first 65 minutes, you're still looking at the same blood vessel. You don't see much accumulation of the rhodamine, the folate-targeted rhodamine. Now, if you keep looking at that same tumor, and at 65 minutes you inject folate linked to rhodamine without that PEG 5000 bridge in between, without that PEG 5000 spacer, you see that that same tumor is saturated within 5 minutes. And so, again, we have not shifted from the tumor. The injection of the second folate linked to rhodamine was also in the tail vein at a distant site. And you can see how quickly it saturates the tumor. This next slide here shows the time course of the fluorescence intensity in the tumor and how slowly and often inadequately the larger targeted molecules enter and accumulate in the tumor, and how rapidly the smaller molecules enter and accumulate. This turns out to be important primarily if you want to image the patient on the same day as when they come into the hospital. If you use a smaller molecule, you can image within an hour or two of injection of the tumor-targeted fluorescent dye. If you use the larger ones, you have to wait for several days. And so for the convenience of a patient, we often go with the smaller molecules. We also believe in our comparisons that the smaller molecules end up revealing a brighter tumor because there are more, they reach and occupy more binding sites. Again, in this example here, both the larger and smaller molecules are targeted with the same folic acid, and both have the same rhodamine dye on them. So the only difference is size. These are data from another group that have looked at the accumulation of Herceptin, a commonly used antibody to treat breast cancer, in human tissue in humans. And the red color designates the blood vessels, the blue color designates the Herceptin antibody distribution, and the green color designates hypoxic regions of the solid tumor. And you can see that the Herceptin accumulates almost exclusively in regions surrounding the blood vessels and not in hypoxic regions of these tumors. In fact, there are often even non-hypoxic regions that aren't green, that don't contain significant blue color. This just indicates the limitations of moving a large molecule into a solid tumor. Even oxygen, a diatomic molecule, does not penetrate solid tumors very well. And so that's the reason why you have hypoxic regions. So that is the reason why we select smaller molecules for developing tumor-targeted fluorescent dyes. Let me go through a number of different tumor-targeted fluorescent dyes that we have developed in our lab, all using very small molecules. The first one targets the folate receptor. Because cancer cells have an enormous appetite for folic acid, they often express a folate receptor that normal tissues do not express. This folate receptor is expressed or upregulated on about 40% of human cancers, including, as you can see in this cartoon, triple-negative breast cancer, kidney cancers, colon cancers, non-small cell lung cancers, endometrial cancers, and ovarian cancers. And this video here that you're going to see now shows two different views of a surgery of a human with ovarian cancer. The lower right panel shows the image that the surgeon currently sees without the aid of this tumor-targeted fluorescent dye. And the upper left-hand panel shows the image that the surgeon sees with the aid of the tumor-targeted fluorescent dye. So you can see it would be very hard to distinguish malignant from healthy tissue in the lower right-hand panel. But up in the upper left-hand panel, you can see that the cancer tissue can be easily seen. This is using OTL38, a dye that we have been using. It is now in phase 3 clinical trials, near the end of phase 3, and it's performing very well. These data were provided by Alex Varmeyer at Leiden University Medical Center in the Netherlands. This next slide here shows in the upper left-hand corner, again, these are all human data, how small the lesions are that can be seen using these tumor-targeted fluorescent dyes. Some of these lesions that you can see in the upper left-hand panels are only a few cancer cells in size. We can see down to even a single cancer cell if you have a microscope, but with a standard imaging camera, you can see often down to a cluster of 5 or 6 cancer cells. The applications are, as you can see here, seeing very small malignant lesions and making sure that you remove all malignant disease. In the center panel, you can see that in this case, Sunil Singhal at the University of Pennsylvania used it to find a synchronous lesion that was not visible in the CT scan, but was only found during the fluorescence-guided surgery. On the right, a lymph node that would have otherwise been missed has been uncovered and removed. In the lower left-hand panels, again, are buried lymph nodes that could have been buried up to 1 or 2 centimeters deep in the patient's normal tissue that would have been otherwise overlooked, that can be identified and removed. And then in the lower right-hand panel, it's often possible to remove this. In this case, this is Dr. Sunil Singhal's data at the University of Pennsylvania. Upon moving a wedge section from a patient with a lung cancer, he found that the fluorescence went right to the staple line, indicating that he had a positive margin. This allowed him right within a few minutes to go right back into the patient and remove the rest of the diseased tissue. Here's another image. This is obtained by John Lee at the University of Pennsylvania. It's a brain cancer, and the video shows that in this case, he's going up through the nose into the brain to remove the lesion. And in the course of this, he sees that there's extra fluorescence on the top wall up there, if you look up at the top of the video. This he can't reach with the rigid metal utensils that he's using to cut out the fluorescent lesion. But because he sees it, he knows that he has to cut a opening into the skull and remove that extra tissue, diseased tissue, in a separate surgery. And he's done this. And it turns out that a week later, when they went back in, the tissue is still fluorescent. Another targeting ligand is PSMA, or targets prostate-specific membrane antigen. This has been designed. We designed it using the crystal structure in the lower left-hand corner. The same targeting ligand, as you can see in the bottom center, has been used for delivering. We've used it for delivering a radiotherapeutic agent to patients with metastatic castration-resistant prostate cancer. And the image on the left shows before treatment. The image on the right shows after treatment. Works very well. We also have fluorescent images. This is now in late phase 1 clinical trials. Another one is carbonic anhydrase 9. Carbonic anhydrase 9 targets virtually all solid tumors, because virtually all solid tumors are hypoxic in regions, and a mosaic throughout the solid tumors. And because of that, if you target a drug to this enzyme, carbonic anhydrase 9, it's easy to pick up virtually every solid tumor. And here we have an image of an implanted tumor on the surface of a mouse. The mouse was injected in the tail vein. The same fluorescent dye was used for delivery of a fluorescent probe. This is gamma-glutamyl transpeptidase. It's also present on virtually all solid tumors. Again, in this case, we see uptake in the tumor and the kidney, but the kidney is a site of excretion. You don't see uptake in any other tissues. Another one that we've developed is a cholecystokinin 2 receptor. It's found in a number of GI tract cancers and some other cancers. It's indicated on this slide. And this one is not in clinical trials, but it has some promise, especially for gastrointestinal stromal tumors and similar ones. This just shows some mouse data where we've injected in the tail vein the tumor-targeted fluorescent dye shown in the upper right-hand corner of the structure that we designed. You can see that it's very specific for the tumor. We also have tumor-targeted fluorescent dyes for neuroendocrine tumors. This one targets neurokinin 1 receptor, and this is overexpressed on a number of neuroendocrine tumors. And again, the story is the same. The cancers that it can target are in the lower left-hand corner. This is not yet in human clinical trials, but it has the potential to move in that direction. Together with a group from Johnson & Johnson, led by Karen O'Neill, I think she started a separate company with this, we have used a centaurin, a small peptide, to target the EGF receptor. And to this small peptide, again, we've attached the same fluorescent dye, and one sees the same results. This is a little larger than the small molecules we use, but nevertheless, it works very similarly, and I think it gives very sharp images for EGF receptor positive cancers. In the closing minutes of my talk, the last 10 minutes, I'd like to just tell you some of the directions we're going now in the future, and I believe these have great potential. I have to introduce this in this slide here and just summarize for a few moments what cell types are commonly found in solid tumors. And in addition to cancer cells, solid tumors almost always contain a number of stromal cells. In some cases, the stromal cells can constitute more than 80% of the cells in a solid tumor, including pancreatic cancers, for example. And in most of their solid tumors, there's certainly well over a third of the cell types in a solid tumor. These non-malignant cells in the tumor are not mutating, so they make stationary targets. In other words, they can't mutate to lose a specific antigen that you're targeting your fluorescent dye towards. These will not be changing, and so they will be common to virtually all solid tumors, and they won't be mutating. What are the cells that constitute these stromal cells? They can be innate immune cells like tumor-associated macrophages, myeloid-derived suppressor cells, tumor-infiltrating lymphocytes, cancer-associated fibroblasts, and so forth. And then also the tumor vasculature, which is different from normal tissue vasculature. And we have designed targeting ligands to target all of these cells. These are just stains of different human cancers for tumor-associated macrophages and myeloid-derived suppressor cells, abbreviated at the top of this slide as TAM and MDSCs. They both, it turns out, express an isoform of the folate receptor called folate receptor beta. And even though these myeloid cells express folate receptor beta, normal healthy myeloid cells do not. And so one can use these to target attached fluorescent dyes very specifically to malignant tissues. And you can see the stains. It's the brown stain in all of these tumors, in skin cancer, bladder cancer, liver cancer, renal cancer, brain cancer, and thymus cancer. The density differs among different cancers, but all cancers have these TAMs and MDSCs. we have an image in mice, and this tumor, it turns out, the cancer cells themselves are folate receptor negative. They do not express any folate receptors, but they are characterized by an infiltration of these TAMs and MDSCs. And because of this infiltration, we see very good images of the tumors. In humans, this is an image by Sunil Singhal at the University of Pennsylvania. It's a video. On the left side, you see the normal view. On the right side, you see the fluorescence view. This is a young teenager, a girl with metastatic osteosarcoma. And these cancers are largely folate receptor negative, and the images are largely a consequence of the infiltration of TAMs and MDSCs. Sunil tells me that he's seen a number of lung cancers where the cancer cells are folate receptor negative, but he's still able to see them due to the significant infiltration of these TAMs and MDSCs. Another common cell type that are non-malignant but are very abundant in solid tumors are the fibroblasts. These fibroblasts upregulate in tumor tissue after they're activated by tumor-associated macrophages and myeloid-derived suppressor cells. These myeloid cells secrete cytokines like CCL18, PDGF, TGF-beta, and other fibroblast activating cytokines. They activate the fibroblasts to become myofibroblasts, and the myofibroblasts secrete collagen, and the collagen is what makes solid tumors harder or more rigid than adjacent normal tissue, and that's the reason why all solid tumors are rigid. Anyway, one can target these fibroblasts by targeting FAP, fibroblast activation protein. We've developed several ligands for targeting FAP. They're very specific for solid tumors, and they give beautiful images in animals. We have not taken this into humans yet, but others have used related FAP-targeted PET imaging agents, and as you can see here in this article by Giesel et al., that you can see the pancreatic cancer, the spot up in the esophagus, up in here for the esophageal cancer. This is non-small cell lung cancer here. You can see head and neck cancer here. You can see the colon cancer down in here. It images virtually all human cancers. And of course, in all cases, you see the bladder and the kidneys where the sites of excretion of this PET agent. But other than that, the images are largely devoid of any contaminating uptake in normal tissues. So it's a very good targeting ligand. Finally, at the very end, I just would speculate that it might be possible to use targeted fluorescent dyes to image healthy, normal tissues to help the surgeon avoid accidentally cutting some of these tissues that one would not want to cut. And I just put in two examples from our own lab, one in collaboration with Fernando Dip at Cleveland Clinic and also in Argentina. He has found that one of our fluorescent dyes can image the ureters, which can be accidentally severed during surgeries for colon cancer or endometriosis. And you can see here that it's very hard to tell which of these many tubes in this, it turns out this is an operation on a pig, is the ureter, but when you use the ureter highlighting fluorescent dye, you can see it's underneath that vascular bed, and it could have been accidentally cut during one of these abdominal surgeries. And the last slide shows that our ability to target fluorescent dyes to nerves. Nerves are present throughout, and there are a few of them that are, when severed, lead to a significant morbidity. For example, during prostate cancer surgeries, if the nerve that innervates the prostate is cut, the cancer patient can, as a consequence, be either impotent or incontinent or both. And guys don't like that. And so avoiding severing the nerve can be very important. And by highlighting it, we can help the surgeon avoid that. This slide shows a list of the targeting ligands we've developed in our lab for targeting for imaging cancers on the left, for imaging different kinds of inflammation in the middle, and for imaging other diseases like viral diseases and other sorts of things on the right. And this last slide summarizes those that have contributed to all of these studies. The ones with stars by them have been especially valuable in developing this technology, and I want to thank them most sincerely and enthusiastically. And the others have also contributed significantly, and I'm grateful for their contributions also. And with that, I will stop the talk. I think I'm right about on time, and answer any questions that you may have.
Thank you, Dr. Lau. And as a reminder, before we start answering all the so far submitted questions, you can still submit your questions through the question pane in your attendee control panel. So, Dr. Lau, our first question coming in is, how do you design your low molecular weight tumor-specific targeting ligands?
How do
you design? Yeah.
Oh, design them. Oh, thank you. That's a good question. Yes, we actually take 3 different approaches to designing them. First, if someone elsewhere in the scientific community has already designed an inhibitor, for example, an inhibitor of the EGF receptor, and it binds to an external exposed site on the EGF receptor, we would use that because it's a small molecule that already has been optimized to bind with very high affinity to that receptor, and then we can use that as the targeting ligand to carry and attach fluorescent dye. That's the easiest approach, and that works in about maybe a third of the cases. In another third of the cases, if the crystal structure of the tumor antigen or receptor is known, we can use that crystal structure to design a small molecule that might fit into some pocket on the surface of it. In the case of PSMA, we actually use this strategy, this method for designing the targeting ligand, and that's how we design the targeted fluorescent dye that targets PSMA. In another third of the cases, we just used high throughput screening. We just screened maybe 500,000, 800,000 molecules using a high throughput robotic screening strategy to identify one that might happen to bind. Use those 3 strategies.
Thank you. Another question that came in is, why did you choose the Kodak dye S0456 for use with all of your tumor-specific targeting ligands?
Yeah, that's a good question. We've used that because for a number of different reasons. First of all, it was very inexpensive, and it is extremely bright. It is as brighter than isocyanin green, which has been commonly used for fluorescence-guided surgery. And it's about it's much cheaper depending on where you purchase it. Second of all, it has the same wavelengths as isocyanin green, both excitation and emission. And so cameras that were already constructed for viewing isocyanin green during surgery be used to image all of our tumor-targeted fluorescent dyes. So the surgeon doesn't have to buy a whole new optical system to image our dyes. So those would be, and also, unlike isocyanin green, it does have a chemical moiety on it that renders it easy to conjugate to all different tumor targeting ligands. So the chemistry is very simple.
Thank you. Another question that came in is, one of the problems we are facing with NIR guided surgery is penetration of the light. Some tumors cannot be recognized if they are in the middle of an organ. How would you resolve that problem?
Well, that's a very good question, and the solutions to that are not easy. Obviously, if you can develop a brighter dye that has, or a dye that has a larger extinction coefficient, you can capture more of the incoming light, or if the quantum yield is higher, you can generate more outgoing light or fluorescence. So making a better dye can obviously solve the problem. I'm not sure which dye the questioner is currently using. Another possibility is to use other strategies that are being developed besides just fluorescence. Photoacoustic imaging is where you send in light, it activates an acoustic wave that allows you to detect this acoustic wave at much greater depths. I think this is being explored by a number of labs that are developing the instrumentation. I think it's potential to visualize malignant lesions that are buried much deeper. Then there's, moving to other wavelengths. There's some far infrared imaging dyes that are being developed. I think their quantum yields right now are very low, and so there has to be improvements in the chemistry before they can be used practical application. And then using fiber optics or using attached radio imaging agents. Some people are exploring attaching radio imaging agent and using that to locate the general position of the dye, of the target dye, and then on the same molecule using the fluorescent dye to assure that one resects all the malignant disease and leaves no positive margins and so forth behind. I think there are a number of approaches. None of them are really currently practical for application in the clinic, but I think with some additional research that these options will become more viable.
Thank you. Next question right now is as well the last question. So if you have any more, then please send them in right now. And last question so far is, outside of cancer surgery, where do you see fluorescence-guided surgery improving the outcome of surgeries?
Yeah, that's a good question. Obviously, right now, at least in the clinic, the only applications that I know of that are being actively pursued are going after cancer, but there are a number of benign lesions like the benign pituitary adenomas. They're not malignant, but they continue to grow, and at the site of the pituitary gland. And if they are not completely removed, if this tissue, it's a diseased tissue, but it's not malignant, if that diseased tissue is not completely resected, then it grows back. And it's not uncommon for a patient to have to go in for a second or even a third surgery to resect a diseased tissue that was missed during the first surgery. I think that's the case also with other benign lesions that aren't malignant but still grow, like endometriosis. There are 500,000 endometriosis patients a year in the US, and during every menstrual cycle, this tissue expands and grows. And if this escapes into the peritoneal cavity and causes the endometriosis, if this growing tissue is not removed completely and quantitatively, then it continues to grow back. And so identifying it with a fluorescent dye that targets specifically the endometriosis tissue would greatly help the surgeon avoid these subsequent surgeries. I think there are others of those sorts. I think one could go after a number of different inflammatory or autoimmune lesions, like sarcoidosis might be important to resect. Also, there are pre-malignant lesions like polyps or other pre-malignant lesions in colon cancer or in Barrett's esophagus, and that might be important to find and quantitatively resect to avoid the subsequent development into cancer. And I think there are even some situations where infectious lesions are hard to find. Infectious sites are hard to locate. They know that the patient has it, but they can't specifically find it. And some of them, the only way to actually, they don't respond to antibiotics, and the only way to really get rid of the problem is to cut it out. And so I think that might be a good solution. So I think there are a lot of applications. They remain to be explored. I think there are opportunities to develop tools for these surgeries also. So I hope that answers that question.
Thank you. Couple of other questions came in, maybe in regards to time. We may not be able to answer all of these, but maybe one other question. What needs to happen in order to convert this technology in standard of care?
Well, I think that's a great question. I think, first of all, we'd like to develop tumor-targeted fluorescent dyes that cover essentially 100% of human cancers, at least those that are commonly removed by surgery. And I just remind everyone that I think surgery is complete surgical resection is the only absolute cure for cancer. There's still so many cancers that find ways to mutate around the chemotherapies that are, or radiotherapies that are otherwise used to try to eliminate them. And if you can completely resect all the malignant disease, you can be sure you're cured. Right. I think that the instrumentation probably needs to be improved. I think we need to make it a little bit more user-friendly to the surgeon. Right now, most of the cameras force the surgeon to view the surgical region on a separate monitor, so they're not looking directly into the patient. I think that will make it more readily usable. I think most surgeries are going robotic or at least endoscopic, and I think developing the cameras that work very well for endoscopic or robotic applications will be very important. I think, as I was alluding to, where I got distracted on another line of thought, I think we need to make sure we have tumor-targeted fluorescent dyes that will cover all different kinds of human cancers that at least are removed by surgery. Those will be the major developments that have to occur in order to really make this widespread. I believe personally that 10 years from now, those tumors for which these dyes and instruments are optimized will be almost exclusively removed using these tools. I can't imagine a surgeon wanting to go in without the aid of these tumor-targeted fluorescent dyes when they can make such a difference in finding synchronous lesions or residual tumor in the tumor bed, or lymph nodes and things like this. I can't imagine anyone wanting to go in and perform surgery without this extra capability of seeing otherwise occult disease. But I think with a few more fluorescent dyes and a few improvements in the instrumentation, it will be more widely used. So, and I anticipate that will happen.
Thank you, Dr. Lau. With that, we are already running out of time. So thank you everyone for attending today's webinar. Once you leave today's session, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view recording of today's webinar. On behalf of International Society of Fluorescence Guided Surgery, with grant funding from Diagnostic Green and our presenter, thank you for joining us today and enjoy the rest of your day.